Okay, let's dive right in. One of the most common things you're going to see in a task case question is a low MCV. Now look, anyone can memorize a list of 4 causes, right? But that's not what gets you the top score. Understanding the why, the mechanism behind it, that's the real game changer. Okay, Harjam, so this is the classic starting point. You see MCV 72, and the options on the exam always look so similar. So how do we start thinking like an examiner? How do we separate these differentials from the get-go instead of just guessing? Great question. We start with the heavyweight champion, the most frequent cause, Iron Deficiency Anemia, or IDA. But we're not just going to list the findings. No, we're going to understand its story. And that story begins with how the body actually handles iron. What's really key to understand here is that IDEA is a true, honest-to-goodness lack of raw material. Think of it like a factory. For IDEA, the delivery trucks just aren't bringing enough steel. There simply isn't enough iron coming into the system to begin with. So, in a case question, if we see a patient who's eating soil, pica, or has those classic spoon nails, should our brain just immediately scream iron deficiency anemia? These are the classic clinical clues they love to put in the vignettes, right? Exactly. And this lab profile, it's not just a list of up and down arrows. It tells a story. Look, the iron stores, ferritin, are completely empty. That's the first thing to go. So what does the body do? It panics. It screams for more iron by building more transport trucks. That's your TIBC going way up. The problem is there's no iron to put in those trucks, so the saturation is pitifully low. Okay, IDA seems pretty straightforward then. But what about the others? This is where TUS gets tricky. They love to test the mimics, where the MCV is low, but the underlying mechanism is completely, totally different. And our first mimic is the anemia of chronic disease. Now listen closely, because this is the crucial point. The body has plenty of iron. The problem isn't a supply shortage. The iron is just being hidden, locked away inside macrophages because of some chronic inflammation or malignancy. It's a sequestration problem. Ah, hokum, this is the most common trap. Both have low serum iron, which is confusing. So the key differentiator has to be ferritin and TIBC. But why is the TIBC low in ACD? That feels counterintuitive. If you can't access iron, why would your body produce fewer transport proteins? Excellent question. And understanding that is the key to everything. The body is in a state of war. It's actively trying to limit iron availability because bacteria and cancer cells need iron to survive and grow. So the body intelligently says, let's stop shipping iron around, and it produces fewer transport trucks, a lower TIBC, to stop the enemy from getting supplies. It's a defense mechanism. Okay, next up, thalassemia. Here, the problem is entirely different. Let's go back to our factory analogy. The factory is overflowing with raw materials, plenty of iron. But the blueprint, the actual genetic code for the globin chains, is faulty. The assembly line is just making defective products. And this slide right here is a super high-yield pearl for the exam. So in a TUS question, if the MCV is crazy low, like in the 60s, but the red blood cell count is paradoxically high or normal, we have to be thinking thalassemia trait, not IDA. The body is churning out tons of these small, defective cells. And our final mimic, Sideroblastic Anemia. Again, iron is abundant. It even gets delivered correctly to the factory, into the precursor red blood cell. But the very last step of assembly, putting the iron into the heme molecule, is broken. It's a failure of the final chemical reaction. And because the iron can't be used, it just piles up in the cell's power plants, the mitochondria, forming that classic ring around the nucleus. This leads to the absolute buzzword we see on a bone marrow biopsy slide in a TUS question, the ring sideroblast. That's diagnostic, isn't it? Correct. It's pathognomonic. So now let's do it. Let's put it all together on one slide. This right here, this is the mental model you need to have in your head to solve any microcytic anemia question they can throw at you. Let's walk through this logically. Notice how iron deficiency anemia is the only one with a high TIBC. That's your body screaming for iron. Now look at IDA and anemia of chronic disease. Both have low serum iron, but look at the ferritin and TIBC. They're perfect mirror images of each other. That's your key differentiator. And then you've got thalassemia and sideroblastic anemia. These are fundamentally states of iron overload. The body can't use the iron it has, so of course, serum iron, ferritin, and saturation are all going to be high or normal. You see? By understanding the mechanism, This table stops being about memorization. It's just logic.
Precisely. It's all about logic. Now, let's just summarize the key takeaways. The absolute must-knows, to lock in this knowledge and master those two as traps.
Remember this simple algorithm, and you will navigate these questions with confidence. The second you see a low MCV, your eyes should immediately go to the RDW. Is it high? Think IDA. Is it normal? Think thalassemia. That first step guides your entire thought process.
Okay, so let's apply that logic to this final challenge. We have a low MCV, a normal RDW, and a high red blood cell count. Well, putting it all together, that pattern is screaming thalassemia trait. It just has to be. Understanding the why makes it crystal clear.
Exactly. You've just cracked the code. You see? Now you have the framework to think, not just to memorize. And that is how you conquer these questions on exam day.